to the World Massage Conference.
Hello and welcome to the World Massage Conference pre-conference series for the 2011 conference program. I'm your host, Eric Brown, along with my co-hosts Scott Dartnell and Melanie Hayden. I want to welcome everyone on board for this presentation with famed massage expert Ben Benjamin, who's going to be talking about unraveling the mystery of cervical pain. Before we get into our interview, though, I'd like to thank our global sponsor, Massage Envy. Massage Envy is the leading employer of massage therapists in the United States. To discover the benefits of choosing Massage Envy as your career, visit their website at www.massageenvycareers.com. And thanks so much for all our sponsors, the Associated Bodywork and Massage Professionals, Massage Warehouse, Massage Today, Bon Vital, BioFreeze, Massage Magazine, and the Upledger Institute. Here tonight with us on the World Massage Conference to start off our Spring 2011 conference program, we bring you one of the world's top leaders in the massage industry, Ben Benjamin. For millions of people, chronic neck pain is a serious and frequently debilitating problem. Often conventional treatments are of limited help, with medications providing only temporary relief. In this presentation, Dr. Benjamin will discuss the single most common cause of cervical pain, central ligament sprains, including whiplash injuries. You'll learn about the relevant anatomy, assessment tests, and effective treatment techniques that can reduce, prevent, and eliminate severe and chronic neck pain. Now, it's my pleasure to introduce Dr. Ben Benjamin. Dr. Benjamin is a well-known and respected educator, author, and practitioner in the massage therapy field. Ben Benjamin is a leading expert on orthopedic assessment and treatment of soft tissue injuries. He holds a PhD in sports medicine and education and is the founder of the Muscular Therapy Institute. After studying with Dr. James Cyriax, who's commonly known as the father of orthopedic medicine, he began teaching the techniques Cyriax developed and adapting them for treating neck and back injuries. Dr. Benjamin has taught the principles of orthopedic massage for more than 35 years through hundreds of articles, the popular book Listen to Your Pain, several series of DVD programs, frequent workshops throughout the country, and most recently, webinars. And over the past few years, he's created a series of DVD programs on the assessment and treatment of the low back, the neck, the knee, and various common injuries. He teaches weekly webinars on orthopedic massage now on every part of the body. Ben, it's a pleasure to have you here at the World Massage Conference for the second year in a row.
Thank you so much.
And I want to say again that if our listeners haven't done online education before, they're in for a real treat tonight. So what I'm going to do is just hand the mic over to you now and leave the audience in your very capable hands.
All right. So let's move on to the slide that has the goal of this webinar, Melanie. So the goal of the webinar is to explore the assessment and treatment of the most commonly debilitating chronic injury to the neck. And I'd like to, the next slide please, thank you for joining me on this journey into cervical pain. Hopefully you won't feel pain, but you'll know more about it. Millions of people, as Eric said, suffer from neck pain, and they really have no idea why they have neck pain. They wake up in the morning, they have neck pain. They, bend down to pick something up, or they turn their head in their car, whack. They just feel like something happened to them. They don't know really what it is. And it's not that hard, in most cases, to figure out exactly what the difficulty is and to treat it successfully. Now, before I start teaching, I like to give you a pretest to give you a sense of what you know and what you don't before we begin. So if you don't have a pencil and paper, run and get one, but hopefully you do. And just put on your paper the numbers 1 through 6. And we'll take these pretest questions one at a time. So I'll read them out to you. 1. Which structures in the cervical region are the most frequent cause of chronic pain? A, the occipital muscles. B, the supraspinous ligaments. C, the scalene muscles. And D, the sternocleidomastoid muscles. Just write down A, B, C, or D, whatever your answer is, or the words if you'd like. And then we go to the next slide, which is question 2. Question 2 is the most frequently injured ligament in the neck is the C4 supraspinous ligament. Is that true, or is that false? And we go to the next slide, number 3. The term whiplash refers to a specific injury. Is that true, or is that false? And now number 4, ligament injuries in the lower neck can cause headaches. Is this true, or is this false? And moving on to the next slide, number 5. Most of cervical rotation takes place at the C5 vertebra. True or false? And number 6. Cervical ligament injuries can cause pain in the hand. True or false? So now you can put those away, and hopefully you're going to know the definite answers to those at the end of this webinar, and you're going to take a little test, and you'll know it. Cervical pain is the second most common cause of pain and injury in the human body. The lower back, of course, is first. Now, according to a recent study, between 50 and 100 million Americans suffer from pain in this area, and probably millions more from around the world. I learned about neck injuries firsthand by actually having one, and it's not really a fun experience. It's as debilitating as a low back injury. It really hampers your life, so that you really can't do anything, and you lose your energy, you lose your excitement for life, and it's very difficult to do anything if you have a severe injury, or it can be kind of a nagging one. Now, many people start the injury cycle through their involvement in an accident, usually a motor vehicle accident, but not necessarily. And commonly this is referred to as whiplash. So let's go to the next slide, the whiplash slide. Whiplash is a sudden physical action of acceleration-deceleration force that occurs during an accident, which causes damage to the cervical fascia, ligaments, muscles, and sometimes other structures in the neck. It usually occurs as a rear-end collision when the person is sitting in their car, minding their own business at a red light or a stoplight, or a stop sign, Whiplash can also occur from a side-to-side impact, not just sitting in your car and having a whiplash, or it can be from the impact of a head-on collision. It can also occur by colliding with another person during a sports event. The motion of whiplash is generally posterior to anterior, but it can also occur laterally from side to side. It will often be accompanied by a concussion to the head if the head snaps back and hits something, like in a car, or if you fall after a whiplash when someone bangs into you. It is not, now I repeat, it is not a specific injury. It's an action that causes usually multiple injuries that can be short-lived or can turn into chronic pain. I remember I had a couple see me very soon after they were in a whiplash accident, and the man took 2 treatments to be completely well. His wife had to have 20 treatments in order to be well. Same exact injury, same exact accident, same car. Depends on what you come to the table with and what condition the person's neck was in at the moment. If they would turn their head slightly to the side, it might be worse. It just depends on the person and the circumstance. So just because you have a whiplash accident doesn't mean you have to have pain, but other people have pain for 10, 15, 20 years after that incident. So go to the next slide, please. This same exact injury or damage that happens to the neck ligaments and muscles and fascia can occur slowly over time instead of suddenly in an accident. So what are the typical causes of neck pain that look the same way? One is overstretching the neck repeatedly over time. So, for example, if you are doing a shoulder stand for 5 minutes at a time, and you're really pushing the neck too much for too long, you'll distend the ligaments and weaken them, and also the fascia as well. Another one would be a lack of body use. For example, in a job that requires constant sitting at a computer or at a telephone for many hours a day. Or a person not really interested in getting any exercise, so they don't do anything, and their body sort of deteriorates, and then some small thing happens, and they're going to tear some of the structures that cause pain. Sleeping, also in an awkward position, or on a pillow of the wrong height for you, like when you travel or you stay at a hotel or a friend's house. You're on a pillow that's either too high or too low, and your neck slowly stretches through the entire night. With ligaments are not supposed to stretch, and if they do, you can tear some of the fibers. Or poor body use, for instance, a forward head posture. I've treated a number of dentists who seem like they were born with a forward head posture because they're always in that position. And there are many more slow onset causes of neck pain. These are just a few. So let's move on to the next slide in the anatomy. Now we're going to look at the most commonly affected structures in the neck when there is a severe or chronic injury, whether due to an accident like a whiplash or from these other causes that I just discussed with you. Let's go to the next slide. First, let's consider the muscles that are usually affected when there's neck pain. The occipital muscles of the neck, both deep at the base of the occiput and the superficial occipitalis muscles right at the back of the cranium, about an inch above the base of the skull. This is part of the occipitofrontalis muscle that goes over your head and down on your forehead and controls your eyebrows. So you can have pain that goes all the way over there. The splenius cervicis and capitis muscles at the back of the neck also get torn. The sternocleidomastoid muscles that help you rotate your head, and also the scalene muscles at the sides of your neck. These structures get injured frequently, but they also heal fairly quickly because they're highly vascularized. They have tremendous amount of blood circulation. They get injured, but they don't stay injured for all that long, usually. Now, if you've ever experienced the experience of working on a cadaver, you can see this striking difference between muscles, ligaments, fascia. Muscles are red. Ligaments and fascia are kind of white. The muscles have enormous blood circulation, and the ligaments and fascia do not. Next slide, please. Next, let's look at the ligaments in the cervical region that are usually affected the most. The fibers of what we call the supraspinous or nuchal ligaments in the cervical region are commingled. They overlay one another. I'm going to refer to them as one structure because functionally they work together. Technically, the nuchal ligament is superficial to the supraspinous ligament. This series of ligaments connects the tips of the spinous processes in the neck, as you can see in this drawing that I had made that I took out of my own book. So take a moment, actually, let's feel it. Take a moment and put one of your hands on your neck at the lower cervical and just see if you can find those bumps anywhere along the back of your neck. Now first, feel it and go around it a little bit. These are the spinous processes, the protrusions you see in that drawing on the slide. Then feel the dips in between those vertebrae and between the spinous processes. Now, in either of those places, you are on the nuchal and supraspinous ligaments that we're talking about. Now, they go from C7 at the cervical spinous process all the way up, trace it all the way up to your skull, to the occipital protuberance, that big bump at the back of your skull. These are incredibly important ligaments that are so frequently overlooked. Let's go to the next slide, please. Now we have the interspinous ligaments, which lie deep to the supraspinous ligaments. So you have these spinous processes, and I just showed you the edge of it, where the thing you could feel. But if you went 2 inches inside, or a half inch inside, or inch and a half inside, you had another ligament that holds those together. So they're the next layer of tissue attaching the deeper surfaces of the spinous processes to one another. Now these ligaments run from the base of one spinous process to another and can be 1, 2, 2.5 inches deep, depending on the size of the person. Now because they're so deep, they really cannot be treated manually. And unlike the supraspinous ligaments, the interspinous ligaments are not contiguous from one vertebra to the next. So let's move to the next slide now. Now we come to the intertransverse ligaments. Now these are also very important ligaments that connect the transverse processes to one another, but we're going to have to leave those to another day because they need their own entire webinar for us to go into that in great depth. But basically, if you put your fingers under your ears on your mastoid processes, on both sides, or one side, because you're holding the phone, I don't want you to drop the phone, and press your fingers in, sort of toward the center of your spine, and those hard bumps you feel are those transverse processes, and they're connected by these very important ligaments that also get injured when you have a different kind of pain. But again, we'll leave that to another day. Let's go on to the next slide, the discs. So finally we have the discs. Now the intervertebral discs can be damaged and compressed they can compress the cervical nerves. Okay? When this occurs, pain is very severe and lasts for a really long time, usually a year, maybe 18 months even. Now, disc injuries in the neck are much less common than in the low back. 8% of all disc injuries are in the neck. And according to orthopedic physicians and neurologists, only 3 to 5% of all neck injuries involve a nerve being compressed by a disc. Now, the other day I actually read some new research that even calls that into question, whether discs actually cause any pain in the neck at all. In my experience, when I find the ligamentous problems and the fascial problems and I get rid of those, the pain goes away. So let's go to the next slide, entitled Muscles versus Ligaments versus Discs. So a frequent cause of short-lived pain is caused by injury to the muscles of the neck, just to review what we said, and occasionally a long-lasting injury is caused by a protruding disc hitting a nerve root. But the most common cause of chronic neck pain after a whiplash or a slow onset injury is caused by ligament sprains from C4 to C6, and especially at C5. Now, you can have C4 to 5, 5 to 6. You can have more of them, but generally speaking, it centers around C5. Now, C5 has the greatest curve in the neck and is at the apex of the anterior to posterior movement of the neck in its shape. It generally gets the most force placed on it during a motor vehicle accident, usually referred to as an MVA. So let's now move to the next slide and the assessment test, so we can look at how we assess what's going on here. Next slide, please. First, be sure that the client goes to a physician to see if there's been any really serious damage. Now, this might include a concussion, this might be a broken bone in the neck. You know, they might have a spinous process that's been broken. You might have a vertebral fracture, or you could have a ruptured disc in the neck. Now, those are not things that you're going to be able to help. And in most cases, that's not true. In most cases, it's going to be fascia, ligament, muscle, and in most cases, the central problem will be the ligaments. If it lasts a very long time, that's what it usually is, in my experience. So to assess the neck, you begin with active tests, asking the person to actively move their head to see if there is pain and limitation of movement. So they turn their head, they move it, and we'll go through that in a few moments. In the second set of tests that I'm going to show you, you perform 4 passive tests, which primarily assess the ligaments that we're looking at today. The last tests that you perform are 6 resisted tests, which assess injury to the muscles. Okay, so we move now to the next 2 slides. Then we go active tests, and then we go right to the next slide, which shows an active test, which is a woman turning her head from side to side. Active tests tell you about range of motion and whether the person can move their head without pain. They tell you to be careful. If you see limitation of movement or wincing as they move their own head, you know, you need to be really careful and do the test very, very, very gently and slowly. Now, first rotation, the person can turn their head, and how far can they turn their head is what you're looking at here. So she's turning her head so her chin is over her shoulder. Now, if you can't turn it that far, let's say you can turn it only 45 degrees, it could be that it's limited, which is giving you a signal that something is really going on here that's not so good, or it could be painful, and the person will stop and they'll tell you it's painful, or they'll kind of wince a little bit. Usually they won't go that far. Let's go to the next slide. The next is side flexion. You ask them to bring their ear to their shoulder, and you notice, you know, what happens. Is it very limited? Is it not? And if you notice here, the slide on the left, the person has more movement than if they're putting their left ear to the left shoulder on the right here. It's a little bit limited. So try that yourself. Try turning your head from side to side, rotate your head, see if that hurts you at all. And then put your ear to your shoulder and then your other ear to your shoulder. And then we'll go to the next slide, which is active flexion. So what you do here is you bring the chin down to the chest, and how far does it go? That's what you're looking for. Does the chin touch the chest? Does it cause pain? You're just getting an idea here now. You're not actually getting anything definitive yet. You're just seeing the lay of the land. Next slide, please. There's active extension where you look at the ceiling. Try that. Look at the ceiling and see if you can make your head go absolutely flat to the ceiling. That's the full range of motion. And now bring your head forward if you didn't do it before and see if your chin touches your chest. If your chin touches your chest without any pain, that's a good range of motion. If you're over 50, you should come within an inch of your chest. How many people have this good a range? Not too many. So now we go to the next slide, and that says passive tests. Now, passive tests of the neck give you information about ligaments and sometimes about the discs as well. So let's go to the next slide showing this test number 7, which is a rotation. So what you're doing here is you ask the person to turn their head and drop their chin a little bit. You put one hand on their face, around their jaw, and you put your fingers around the ear, not over the ear. And in the other hand, you put your hand on the back of their head, again around the ear, and you put the forearm at the back over the scapula because they're going to try to get away from you. Because if you turn their head and they have pain, and you do it very slowly, very gently, because they're going to want to move away from you. You want to make sure they don't move so you can actually get the accurate amount of range that they have and when they have any discomfort that starts. And when any discomfort starts, you stop immediately. Bang, you just come right off and you just put them back in neutral. Now, if you put your hands over their ears and you ask them if it hurts, they're going to say, what? And you say, does it hurt? They say, what? Because your hand's over their ears and they can't hear you. Some people do this, so don't put your hands over their ears. People don't like you to put your hands over their ears anyway, but you also want to be able to communicate with the person. So then you're going to go to the next slide, please, and you try passive flexion. You have the person bring their head down. Now, if they bring their head down and it hurts already, you don't have to do this test. And you probably found it out in the active test we did earlier. But if it doesn't hurt, put 2 fingers on the back of their head, one hand on their upper back for sort of some balance, stability, and just bring their head very gently down a little bit more and see if that causes any pain. And see if they have a full range of motion, which is the chin to the chest. In this case, this person does not have a full range. Then you go to the next test. Put your hand on their back so they don't feel insecure. They don't fall backward. Again, put 2 fingers on their forehead and have them go back only as far as they can go back easily. A lot of people, when you ask them to put their head back, they look up with their eyes. That's it. So be very careful. Watch that. That's giving you important information. That means the person's body knows it's going to hurt, and they're afraid to move into that position. So respect that and know that that's really a positive test. You can also ask them, raise your head a little bit more, look at the ceiling, and if they don't or can't, you have your information. Okay, now let's move to the next series of tests, which is the next slide, called resisted tests. Now these tests assess whether the injury is in a muscle or in a tendon. Okay? Resisted test, which is an isometric type of a motion. Nothing moves, but they're using a lot of force. So let's go to the next slide, tests 11 and 12. And this is called resisted rotation. You put your hands on the sides of their head, and you notice as she's going to turn to the right, I let my right hand slip toward the front a little bit into the temple. And I have her turn her head as hard as she can because those muscles should be pretty strong. And here I am checking the sternocleidomastoid muscle. And then I have her, again, do it in the other direction. I check the other sternocleidomastoid muscle. And here I'm looking for pain, and that would be muscular in nature if it hurt. Next slide, please. This is resisted side flexion. Here you put one hand on the shoulder and the other hand on the side of the head, on the opposite side. And you ask the person to try and bring their ear toward their shoulder, and you do not let them. You keep your hand there, and you meet them with equal and opposite force. And you also have to push down on the shoulder a little bit for balance. And you see if it hurts. And here you're testing what muscles? You're testing the scalene muscles. And if they hurt, then you know you've got a muscular injury. Then we'll go to the next one. Here you're testing both SCMs, sternocleidomastoid muscles, and they're going resisted flexion forward, which is usually not painful, but occasionally. And then let's go to the next slide. You put your hand on the very upper chest for balance. Put your hand on the back of the head with the other hand. You're testing the deep occipitals, the splenius capitis, splenius cervicis muscles, and again, have them push back with great force, and it should not hurt them at all if their muscles are okay. Let's go to the next slide now. So what's a normal range of motion? Well, a healthy neck rotates 80 to 90 degrees in rotation in each direction with no pain, meaning that your chin is right over your shoulder, as we said before. Now, over 50% of rotation occurs at C1 and C2. 50% happens right at the top. The rest of the rotation is incrementally spread between C3 and C7. Okay, now let's go to side flexion. A normal neck can side flex 40 to 60 degrees, both right and left. That would be normal side flexion. When flexing the neck forward, the chin should either touch the chest or come within an inch of your sternum when there is full range of motion. Again, as you're older, you lose about 5 or 10 degrees in most cases, unless you're incredibly active, and you may not. I've seen some 80, 90-year-olds who have great flexibility because they've been exercising all the time. They don't just, fold up and do nothing. And they're much, much healthier. They look 20 years younger. And when you look up into extension, the face should be parallel to the ceiling, absolutely flat to the ceiling. Okay, now there are 22 other tests to check primarily for discs and other serious injuries, and we don't have time to cover those in this brief webinar, and should be done under some supervision. And learning the full testing protocol usually takes either classroom experience of a couple of days, 2 or 3 days, or a detailed study of our DVD programs, which describes and demonstrates all 40 neck tests in great detail. But you'll see all of them later when you see me do an assessment on the video that you'll see at the end of this broadcast. So next slide, please. Now we're going to move into the theory, which is where we put it all together. Next slide, please. So let's look at the assessment test results and what they tell us once again. If the muscles are injured, then the resisted tests are going to be painful. For example, if it's painful on resisted side flexion to the right, then what's going to be injured? The scalene muscles on the right are going to be the cause of the pain. However, if you do a resisted side flexion to the right and it hurts on the left, it doesn't mean that the scalenes are injured because they're relaxing. They're not doing anything. It just means that something is moving and it's another structure. Now, if the passive tests are painful, the cause is generally in the ligaments, combined with some fascial scarring as well. Most commonly, rotation is painful and limited when somebody has a neck pain. Okay? And both flexion and extension are often limited and painful as well when there is ligament damage. In the posterior part, when it's on the side, it's a little different. But we're just covering the posterior because that's where most of the injuries occur. When a disc is involved, it is often more complicated, involving severe weakness, reflex changes, numbness, and what we call asymmetrical limitation of movement in the neck. Now, asymmetrical limitation of movement means that you can bend your head in one direction easily and cannot bend it in the opposite direction at all without pain and spasm stopping you. So, for example, if you can flex your neck forward with no problem, maybe little discomfort, but extending the neck back is very limited and very, very painful, this is a sign that a disc may be occurring here. And, of course, you'll send the person to a doctor to check that out anyway, and most people don't have that. And what you do can probably help them. So let's go to the next slide, mechanisms of whiplash. Before we all had cars, the term railway spine was used to describe a very similar accident that happened on trains. And the term whiplash wasn't used until 1928 when people started getting cars. Now, in many cases of whiplash accidents, people recover really quickly without any chronic symptoms whatsoever, but other people continue to experience painful symptoms for years and years and years after the injury. I remember a woman I treated who had pain in the neck after an accident that happened like 15 years ago. No one had ever looked at her ligaments, which were so painful and tender that 1 pound of pressure nearly made her jump off the table. I had to treat her really slowly and gently, usually working an hour in a session on those ligaments in the back of her neck, where with another person, it would have taken 20, maybe 30 minutes tops to do the same thing. But I had to work so gently. So you can work very, very gently and still have a great effect. Now, recent research using high-speed cameras shows that the mechanism of injury is forceful hyperextension and then rapidly followed by hyperflexion. So it whips back then forward. This motion causes the ligaments, the fascia, and the muscles tissues to tear, setting the body up for a possible chronic scar tissue pattern to develop over the next weeks and months if they don't get treatment immediately, which they don't. They usually just freeze and don't move their neck or get a brace or something like that. Let's go to the next slide, please. The other symptoms of whiplash, besides having the pain that we were just talking about in the neck, would be a severe headache, which is frequently followed by chronic headaches. Often this experience is from upper cervical ligament injuries referring pain to the head. Only the upper cervical ligaments, C1, C2, and C3, refer pain to the head. The others refer pain down. You can also have shoulder pain, scapular pain at the medial border. You can be really dizzy, be tired and fatigued. You can get jaw pain, arm pain, visual disturbances, tinnitus, which is a ringing in the ears, or tremendous weakness in your arm. And chronic cases, there are also various emotional states that can include being depressed, being angry, being frustrated, because you can't do anything. You can't move. You can't live. You can't do your job. You can't, pick up your kids. Whatever it is you do, it's very, very frustrating. Next slide, please. Other common mechanisms of cervical injury are you don't use your body. You're just not doing it, and then you suddenly use it. Or you're a couch potato, and then the weekend comes and you play soccer for 2 hours and you don't warm up and you don't do anything else during the week. And then somebody bangs into you and whack. You don't have the kind of power and strength. You maintain the strength of your muscles, your ligaments, your fascia, your everything by using them. And if people don't regularly exercise and then go do something like this, they have big trouble very quickly. Next slide, please. Another common mechanism is something called spondylolisthesis. Now, this is a spinal shelf, which is a radical forward or backward displacement of a vertebra. If you see number A there, it's radically moving anteriorly. So that means if you had your finger on the spinous process, it would be a big dip in. And the shelf is apparent on a standing lateral X-ray, not necessarily when lying down. And in most cases, it can be palpated when standing as well. You run your fingers down the neck, and it just dips in there. Sometimes it can be palpated prone as well, but not frequently. These individuals are prone to disc and ligament injuries because of ligament laxity. They were just born with this particular vertebrae out of place because the ligaments at that level were very, very loose and weren't doing their job. And these people also, if they take care of themselves, they may never have any symptoms at all, but they probably don't play football. Now, the causes of a spondylolisthesis are often congenital, you're born with it, or sometimes through a traumatic neck injury, which stretches the ligaments. Also, an erosion of your facet joints, which causes a slide, or if a person has a bone disease. Next slide, please. Another common mechanism is poor head and neck alignment, which we mentioned before. The forward head posture puts a tremendous strain on all the muscles and the ligaments of the neck. It also makes compensatory patterns throughout the spine, even down into the calf, which has to really work hard because your whole body is forward. Next slide, please. The loss of neck flexibility. For example, if someone has a disease like ankylosing spondylitis or hyperkyphosis of the spine, that's a hunchback posture, resulting in poor posture with the head forward. It could also be a loss of neck flexibility can be caused by a lack of exercise, which we've mentioned earlier, or poor exercise and not really doing exercise well, or just doing strength building and having no program for flexibility to keep the neck really mobile and flexible. Now, if your client has any of the above and they have a car accident and they get a rear-end collision or any kind of whiplash, or they have even a serious fall which jars their head, they're much more likely to suffer a serious debilitating injury than someone who is regularly taking care of their body, exercising, getting massage, eating well, etc. So let's go to the next slide. And these are common injury patterns. Now, as I mentioned earlier, the most common chronic injury that results from a whiplash incident is damage to the supraspinous ligament, especially at C5, which is the apex of that cervical curve. In this section of the ligament complex, there's the greatest amount of anterior-posterior motion and is therefore really vulnerable to injury. And it can tear, and the fascia also sort of follows and surrounds the ligament, and the fascia gets torn along with it. So often you'll have to treat both of those together because they're kind of married. The muscles of the neck are also affected, but they heal much more quickly, as again they're highly vascularized tissue, as opposed to the ligaments, which receive really minimal blood circulation. The sternocleidomastoid muscles are often painful and sore for usually a few weeks, along with the occipital and splenius capitis and cervicis muscles at the back of the neck, but they usually recur quickly. Ligaments do not recover quickly. They take a long, long time. Next slide, please. Now, there are common injury patterns determining which structures get injured. In different parts of the body, different structures are affected most when there's an injury. In the thigh, it's generally the muscles that are affected. In the shoulder, it's generally the tendons or the joint, not the ligaments. In the neck, the most lasting pains are usually caused by damage to ligaments that result in chronic adhesive scar tissue. Now, sometimes all of the supraspinous ligaments are affected. Sometimes just a few, the ones usually around C5, but you can have all of them, and the treatment is very similar. Sometimes the intertransverse ligaments are injured as well, especially if the head was turned a bit to the side. Next slide, please, which shows this little diagram. So let's talk a little bit about referred pain. It's often difficult to identify the precise cause of cervical pain because there's a great deal of referred pain in the neck. So where it hurts to the person isn't necessarily what's going on. So this means you can have an injury in one place, and you can have the pain 6 or 8 inches away from the actual site of the injury. Now, for example, a C5 supraspinous ligament injury can cause pain starting in the lower deltoid, running down to the wrist or the fingers. And another section of it could actually go down to the scapula. And other ligaments can go into the chest, the jaw, all sorts of places, or the back of the deltoid. And it can be very, very confusing unless you have this information. Next slide, please. Now, here are various referred pain patterns. So as you see, the upper cervical ligaments can refer pain to the head, and the lower cervical ones can refer pain to the arm and hand, as well as the upper back, above the level of the scapula, and the chest, as we mentioned in the last slide. So let's go to the next slide, which is we're going to start with the treatment. Now, once you've determined that the supraspinous ligaments are injured, there are many different treatment options you could choose from. And I'm going to talk about a few that I use, which I find effective, and I'm sure there are many, many others. So first here is friction therapy. Dr. Syriacs from London developed this therapy for the peripheral areas of the body, but he never really applied them to the neck or the spine. So in the 1980s, when I was working with him, I developed and adapted the techniques of friction to the cervical spine and the low back as well. Immediately following the webinar, I'm going to show you part of the DVD program, and you're going to see some of that treatment on the supraspinous ligaments. And if they're damaged, this is the primary treatment I use. And also there are some detailed videos, clips that you can get if you join my website. I'll tell you about that later. So you can use these over and over again. Let's go to the next slide, myofascial therapy. This is another important treatment modality when you're working with cervical injuries because the fascia covers all the ligaments, all the muscles, everything, and frequently get damaged and contain scar tissue. The fascia is often affected, when the neck is in pain, and I test for the involvement of the fascia by doing a fascial sweep. If you do any myofascial work, you just do a fascial sweep over the ligaments themselves, and it's going to be really painful. And again, you'll also see that on some of those video clips you can get through my website. Now, craniosacral, next slide. Craniosacral therapy is sometimes another important modality to include in this treatment process because often the rhythm gets really off by a slight concussion. Restoring the natural movement of the craniosacral mechanism, if it's been adversely affected, will help the individual to heal faster and stay healthy. Now, if that's not something that's in your toolbox, time up with somebody who does that kind of work. Next slide. When treating the ligaments, I use massage therapy techniques performed without any lubricant to relax the muscles of the neck for a few minutes before I start the myofascial and then the friction therapy. After the myofascial and friction treatment, I'll take, which can take 15 to 30 minutes, depending on how many structures are injured, I'll often end the section with 10 or 15 minutes of massage with a lubricant. And sometimes after that, I'll use some heat to increase the circulation in the areas that I've been working on to remove the pain-producing adhesive scar tissue. Now, I use massage therapy as more of a primary treatment when the muscles are injured, and I find this is true in a small number of cases. And the chronic cases are usually the ligaments. And just a few more slides here. Osteopathic or chiropractic manipulation is also useful in restoring some misalignment if that's occurred. Next slide, please. I often refer clients to practitioners of the Alexander technique and the Feldenkrais method. These are movement-based therapies that restore the natural movement patterns and alignment in the neck, which is very important. Next slide, exercise therapy, restoring a full range of motion. I use active isolated stretching by Aaron Mattis, and that really restores a full range and strengthens the neck, particularly after an accident. So here I have the exercise I'm showing you here from Aaron's work, showing a stretching protocol of the neck, flexion, extension in all sorts of directions. And he also has a whole series of strengthening exercises as well that are very effective. Then here we have, when there's accumulated chronic occipital and neck muscle tension, it is often a factor in not permitting the person to heal. So I use this device that I developed about 40 years ago with a physician friend of mine, and I call it the neck relaxer, or Ben's block is what it says on it. And the clients like it because it empowers them to reduce their own level of tension by themselves, often a factor either before or after injury to the ligaments. Now what it does is it momentarily increases the level of tension slightly, and then it activates the Golgi tendon organ, which sends a message to the brain that there's too much tension, and it causes the muscles to relax, kind of retrains the person. The person first lies on a rounded edge for about 5 minutes a day, rolling their head back and forth to different places. Then they go to a semi-rounded edge, which exerts more pressure. Then finally to the sharpest edge, which feels great if your neck is really relaxed and healthy, and feels really uncomfortable when it's tense. Now, if it's uncomfortable, they know they've got a lot of work to do. And when the first edge doesn't cause any discomfort anymore, they move on to the next one so it gets more challenging. Now, thousands of people all over the country and actually all over the world are using this device with great benefit. It takes a few minutes to learn how to use it properly. So I placed a video on YouTube that you can have easy access to, and the address will be included later on if you'd like. So here we have questions, or first you want me to talk about the product things that I've got here? Or we got questions now?
Yeah, Ben, we can go to some questions.
We'll go to questions and we can do the product things after.
Okay, because I just want to remind our listeners that if you have any questions for Ben, type them in the Q&A box. You may see the Q&A box on your page, depending on the broadcast page you're on. If you don't, look for a little blue button that says Ask Question, and simply click that button. You'll see a box pop up. Type in your question. Give us your name and tell us where you're from, too. We'd like to know where you're from. And Scott will get on the line here momentarily, and he'll field as many of those questions to Ben as possible. And make sure you stick around after the Q&As. We're going to be showing some video that Ben has prepared for us, and it's really fantastic. And then Ben will be going into the chat room to talk with you personally. Now, I know, Ben, one of the questions we always get at the end of every broadcast is where can people get more resources. So why don't we just take a look at that right now before we take the listener questions. We'll give people a few minutes to submit their questions, and tell us what you have available, how people can learn how to better assess the neck and treat the neck, given this kind of system or approach.
So let's go to the next couple of slides here. If you could advance 2 slides, you'll see that I've got an entire series of webinars on the neck. And what you heard tonight is the first one. So if you call us, we'll give you a discount, and you can get the rest of the series here for a discount you see on the bottom there. And if you go to the next slide, I have a whole series of webinars on the low back, the shoulder, the knee, the ankle. Tracy Walton did a whole series on massage and cancer care, and Tom Myers did an anatomy trained series of webinars as well. And if you go to the next slide, it says special offer. If you join my website, you just go to the website, benbenjamin.com, and it's just a little button there that says click it, and it will bring you to a page. You just put in your name and email address, and you're going to get a free e-book, which is a little book from my How Do You Treat the Low Back, from my book, an extract, so to speak. And then you'll get 3 free videos that you also get, one on using that block, another one on myofascial, another one on the neck ligaments. So that's another thing that you can do. And if you go to the next slide, I'm giving a special offer of $100 off the next DVD series, which has 5 different discs, anatomy really in depth for a whole disc for over an hour on cadaver anatomy, how you test things, how you palpate things. And the second disc is another whole disc of assessment tools, history taking, what everything means. The third disc is how you integrate all that with theory. The fourth disc is all these different treatment techniques, exercises, etc. And the fifth is a case enactment that you'll see part of this evening, plus very common questions that people often ask. So that is the entire thing. If we can go back, and now we can take some questions if you have some there.
Okay, so I'm going to turn the mic over to Scott, who's been taking questions as the broadcast has been going on. You there, Scott?
I am, Eric.
Okay, so I'm going to turn the mic over to you.
Well, thank you very much. Hi, Ben. I have quite a few questions lined up. We'll try and get through to them as many as possible.
Okay, great.
Just wanted to say, as usual, I loved your presentation.
Thank you.
It just flows so well. When you're sitting there, it seems so simple, but we cover so much material so easily, and it just feels so effortless for you. And as a student, I feel like a student sitting back listening. It's always enjoy the experience. Our first
Thank you, Scott.
Our first question comes from Jan in Ottawa, and she says, "Dear Mr. Benjamin, this is amazing. Thank you so much for this overwhelming amount of information." And I think this might be a common question that when you're first training therapists, is that when she treats a whiplash, some therapists are kind of looking at it from one point of view. And you had talked about, symptom A or symptom B, or injury state A or injury state B. How do you get therapists through to that next step to do this assessment piece more thoroughly before they start treatment on someone who's experienced an accident?
It's a great question, Jen, because therapists are always hesitant to do the full assessment. And when I see somebody for the first time, I'll spend 20 minutes just taking their history, which I train people in great detail. We have that on our DVD programs and my webinars. And then you test all the different structures, and you palpate all the different structures. And if somebody, for instance, has a pain that's going down their scapula, you have to find the ligament that's causing that pain into the scapula. Usually it's way up in the neck somewhere. And when people realize that they actually are being a detective, and they really get it. One of the things we do in our trainings is we invite in the public, therapists. Let's say we have like 35 students. And each of them tries to bring in a client that has a neck problem. So we usually get 20 people or 10 people, and they move into teams. And we have people assess for hours and hours. They just assess client after client, take a history, do the assessment, and they share the responsibility of it in teams of 3 or 4. And then they usually have little free clinics. I suggest they have free clinics where they assess their clients, and they bring both of them, 2 or 3 people bring clients, and they all assess them together so they can really get familiar with how do you do this. And then your work is a heck of a lot more effective if you know what you're doing, if you know where to work. Is it the fascia? Is it the muscles? Is it the ligaments? Is it the cranial rhythm? What's going on? You can't just do a massage or do friction. You got to know where to do it. And when they have those experiences, and then they usually get supervision from me or one of my advanced trainers, and then they feel like they know what they're doing. So, hope that answers your question, Jan. Next question.
Great answer. We have Jean in Tucson, and she says, "Why do you do your passive movements upright versus the client lying on the table?"
Okay. Well, the easy answer is Syriac taught it to me that way. And I think what you want is you want to have a little bit of tension on it, because really when people are using their body, when they're upright, there's going to be a certain compression on their system. And I want to see them really in the situation. Like, for instance, if somebody says, well, my knees. Let's go to it. My knee's not hurting me unless I run 5 miles. So I'll have them run 5 miles and run into my office so I can see it actually hurting, not just hear about it. So, I can only say that that's how I was taught to do it, but it makes sense to me. Now, the only time I'll do it lying down is when the person is in a lot of discomfort, just standing there. I know they've got a lot of pain. So then I'll do it lying down. You also can't do certain movements when the person is lying down. For instance, you can't do extension when the person is lying down, but you can do rotation. And if the person is in extreme pain, I think having them lie down is fine. But it'd be very difficult to do extension. You wouldn't want to put them on their stomach and bring their head back. That would be really too tough. So for all those reasons, I would do it standing or sitting. If the person is very tall, you do it sitting so that you're of equal height. And doing it lying down is okay, especially if the person's in a lot of discomfort. Next question.
The next question is from Phyllis Baker in Michigan City, and she wanted you to please talk about treating suboccipitals. And is this a common question for you, Ben, because that's where a lot of therapists see symptoms in their clients, or where they're complaining about specific issues is suboccipitally?
Yeah, that is usually a problem. This is usually injured along with the neck. And in a lot of people, if you take all the people that are healthy and you put them on your table and you take your knuckle and you put it into their suboccipital, most of them are going to jump off the table without any neck injury. So people have huge amount of tension, headache problems, etc., because they have a lot of suboccipital tension. So this can be there in any case. Now, you can also have pain referred to the lower neck by your ligaments. And the muscles of the neck could be constricting and causing pain of contraction because the ligaments are hurting so much, and the only thing the body knows to do when it hurts is contract. So 2 answers. One, if those structures are injured, I would do friction on those muscles, which usually doesn't last very long. The ones that last a long time are usually in the ligaments. But if they are there and lasting a long time, that's where I would work. It's just not been my experience. Most therapists are taught to never touch the spine. I get this all the time when I teach anywhere in the country, anywhere in Europe, Canada. People are taught not to touch it. They don't know how to touch it. They don't know what it is. They don't know how to work with it. And if you don't know how to work with it, that's probably a good idea. But if you start putting your finger right on the spine and going crossways along that ligament, you're going to find tremendous pain, much more than in the suboccipital. Try it out. Next question.
Well, just going into that, I have a question from Adeline, and she asks, how do you check for facet dysfunction, and how common is this as opposed to ligament injury?
I think that facet dysfunction is not very common. You do some other kinds of motions. You go gliding motions, side to side, forward and back. But I find it so infrequently that I don't include that in my standard assessment. So I just think it's not really an issue. I know there was a time in life when everybody thought everything was the facet, and there was a time in life when everybody thought everything was the disc or everything was the muscle, so everything goes through phases here. I don't think that's very common. I don't see it hardly ever. I do see the ligaments most frequently being injured when it's lasting for a long time. Next question.
We have a question from Lisa in West Australia. She asks,
West Australia?
Yes.
Hi there.
Thank you, and she loves the opportunity to, be able to get this information from you. And she was just talking, how do you retain clients, and how do you keep your clients active and in their own work during the rehabilitation process? How do you stimulate your clients to do their work on their own?
Well, the first thing I do is I do a really full evaluation. The first time I see them, I don't treat them. I want to get a commitment. So I do a full, extensive evaluation. I check their flexibility. I check their strength. I check sometimes their whole body, because people come in not only with neck pain, but back pain, knee pain. And I take my book out, my Listen to Your Pain book, and I show them the drawings that I had done that are very simple, that show really what's going on here. And then I tell them about how long it's going to take, which usually for each injury it's going to take, if it's fresh, 4 to 6 weeks. If it's not, 8 to 12 weeks, a couple of times a week. And I want to secure some kind of commitment. And then I really follow through on what I say. If I say I'm going to get them a resource of a person to work with, I make sure I do it immediately. I'm responsible in how I deal with the client. I also give them things to do as soon as I possibly can. I use Aaron Mattis's active isolated stretching and strengthening techniques, which I teach all over the place as well because I think it's just great. So what I'll be doing is I'll be giving them, after the second session, I'm going to give them something to do on their own. So they have an exercise to do to increase the flexibility of their neck, side flexion, rotation, etc. I'll also, after a couple of sessions, if they do have that occipital tension, I want to empower the client to do something for themselves. So I have them purchase one of these neck relaxer blocks and have them start on the easy side with a towel on it because it could be even painful without anything, just on the wood itself. And they begin to see that they can do something for themselves. I don't want people to just be passive. I want them to be doing homework. I want them to having input, not just coming in, lying down, and getting done. I want them to be an active part of it. I also listen to the client. I talk to them every time they come in, how they've been. Are they getting better? If they're not getting better, I'll send them to somebody else who does something different than I do. They may need some structural myofascial work. They may need, movement therapy. They may need something else. So I don't want to keep the client. I want to keep the client if I can help the client. And so you build your reputation one client at a time. And if you do good work, that's the best advertising that you could do, and that's really how you retain your client. And also learn as much as you can. The more you know, the more authoritative you are in what you're saying. You're not just making stuff up. Now, we all make stuff up because we want to understand when we're young. I did that. Everybody does it. Admit it. But when you really learn more scientific information, it really gives you an underpinning that allows you to really talk about your work in a way that rings true to people. And if you give that information authentically to your clients, they will be with you, and they'll come and they'll be committed and they'll stay. So I hope that was the answer you were looking for. Down, under. Try it out. Next question.
Excellent answer. And part of her thing was she's a sole practitioner, and she was trying to find time to make sure she's taking care of each client. But do you think part of the issue is that therapists aren't giving themselves enough time to work with a client, even if they're spending 15 minutes of their own time that they're not billing for, either at the beginning or at the end, to do a proper assessment at the beginning and to work with the client at the end, whether it's to give them exercise or rehabilitative work or hydrotherapy when they get home? Let's roll right into that, Ben, because we're running out of time. What's your thought on using hydrotherapy after your treatment?
I think I take a hot tub every single day and a whirlpool every single day. I think it's great. I don't think it's the end-all, be-all. I think other treatments, I think exercising your neck, getting friction in your neck, and getting massage on your neck are more important. But I think for the self-care part, having a warm bath every night with your head in the water, I think is great. I think getting fresh air, eating well, all of those things are very important, but not really primary. And you said one other thing, Scott, that I think is very important, that you've got to take care of yourself as a therapist if you want to be a role model to your clients. And I wouldn't spend time with clients that I wasn't charging them for. I would spend the time, because it says it's not important. If everything's important, spend an hour, take your time, assess everything, do what you need to do, teach them the exercises. Now, of course, we all run over sometimes if we have to, if something's upsetting or whatever. But get paid for your time. And if the person can't afford your fee, lower your fee, but have them pay for the time. I take people for $25 if they can't afford my regular fee sometimes, or for $50 or for $100. Depends on the person. If I want to work with them, they need to be inputting in some way to get the most out of it, to make a commitment. So that's my answer. Scott.
Oh, fantastic. Shannon in Calgary says, fantastic review, Ben. Thank you very much. Melanie in Cowtown, you mentioned you use heat at the end of the treatment. Would you not use ice?
Well, it would depend. If the person had swelling, for instance, I was working on an ankle, I might use ice or have them use ice. But I'm using an infrared heat that's about 20 inches away from the body to just sort of create a general relaxation and bring the blood up to the surface. On the neck, you don't usually have a swelling problem. And so if you have a lot of tension in the upper back, I might use some heat to relax them. I would only use ice if it was a situation where there was joint swelling. Next.
There are a lot of hydrotherapy questions. I'm switching to Jamie in New Jersey that asks, what exercises are safe and effective for a client that has a military stance or cervical spine?
Well, I would refer you to Aaron Mattis's work, where he has the person do passive flexion. You'd bring the head down to the chest, and then you bring your hand on the back of your head, and you try to bring your head down, not hold it, but move it for a couple of seconds, and then go up, and do that in both inflection and extension. Then there's another exercise developed by a great guy named Paul Chek, does functional movement. I learned this from a fellow who teaches functional movement at a place called Primal Fitness in Gainesville, where they take a blood pressure cuff and you pump it up to like 40, and you put it at the back of the head, and you're going to create, if the person has a military head and their head is really pulled back, you're going to want to create a curve there. If the head is too curved, you're going to push back. So there's not easy to explain on this webinar format, but if you can find somebody who knows how to use a blood pressure cuff for that sort of thing. Another thing I would do is refer them to an Alexander technique teacher, because they work phenomenally with the head and neck in terms of movement. And that would probably be my first thing I would do. And Alexander technique teachers are all over the world, so you probably will not have any trouble finding one. And if you don't know about it, good thing to learn about. Next question.
Well, Ben, thank you so much for taking time. I'm going to turn it back over to our host, Eric. There are still quite a few questions, but you covered a lot of material for us. I know that we were trying to stay specific. I pushed outside a little bit here and there, but thank you very much for answering all the questions so expertly. It's been a pleasure.
Let me just say one thing. If people want to ask me some more questions that I don't get to, I always answer questions on my Facebook page, Dr. Benjamin Orthopedic Massage. They just go to Facebook. They'll find me. And I answer questions every day for people that everybody can see the answers to.
Well, thank you again.
Okay, first I'm going to work on your neck muscles to loosen them up a little bit. And as I work today, your job is to make sure that I don't use too much pressure, all right?
Okay.
So in this session, I'm going to be asking you about pressure more frequently than I will in the future. So for the treatment to work optimally, the pressure has to be a little bit annoying but not painful. So beyond that, more pressure won't help you get better faster. In fact, the pain will slow down the healing process. So if you feel like, grabbing my hand, or you can't wait for the treatment to end, your body's giving you a signal that there's too much pressure. So please just let me know, and I'll lighten up a little bit.
Okay.
So now I'm going to begin working on the covering of the central ligaments in your neck. They're the closest to the skin surface, and this is called the superficial myofascial layer. And just let me know if any of this is painful, okay?
That's a little painful right there.
Okay. Let me try it a little easier. How about now? Is it just annoying or still painful?
Yeah, you can be kind of annoying.
Well, in this case, it's kind of in a good way. Now I'm working on the ligaments in the midline of your neck, and I'm moving across them at a 90-degree angle to begin breaking up the scar tissue that's causing your pain. So how's that pressure?
That's okay.
Okay, good. And how about now over here?
That's painful.
All right. And how about now?
That's better.
All right. Okay. So now working on the edge of the same ligament. How's that pressure?
That's just right.
Okay, good. So now I'm going to work on the base of your neck on the outer ligament here on the side. Tell me what that's like.
Yeah, I feel that down my arm.
I feel it down your arm. Okay. Is it too much?
No, it's okay, but it feels weird.
So what feels weird?
Well, that you're touching my neck, but I feel it down my arm.
Okay, well, what that means is that I'm on a spot that refers pain down your arm.
So we're getting somewhere.
Yeah, we're just beginning, but we already know that we found some of the right places. It's possible that all of your pain is coming from these superficial tissues right near the surface of your body, and that means my hands will be able to reach them. If some of the injured structures are deeper down, deeper inside, I might need to refer you to someone else who can get to those. So how's that pressure?
That's sort of okay.
And does that mean a little too much?
Yeah, I guess so.
Okay, well, how's this?
That's better.
Okay. So now I'm going to work on the back of this ligament. How's that?
Wow, that goes right down to my shoulder blade.
And is it too much?
No, it's okay.
Okay. John, now I'm going to work on that shoulder tendon that's causing some of the pain in your upper arm. Okay, so does your arm hurt sometimes when you lift things?
Yes, occasionally it does.
Okay. So how is that pressure?
That's fine.
How about now? It's a little deeper?
That's a little annoying, but I know you like that.
I'm just going to do a little work on the shoulder today, just to see how it responds. With this first appointment, we're doing an experiment together. We're trying to find out what's right for your body. After this session, you may be a little sore for 24 to 48 hours. I don't mean sore to the touch, just sore when you go through your normal activities. This is a normal result when you're breaking down adhesive scar tissue. If you're sore for more than 48 hours, I'll just adjust my pressure and go a little lighter the next time. And please give me a call late in the day tomorrow to let me know if you're sore and how sore you are. This way I can use the feedback from you to plan any adjustments. Also, you might not be sore at all. So depending on how you're feeling, you can begin doing a very gentle exercise to help speed your recovery. Let me get a pillow and I'll teach it to you now here. All right, so let's put this pillow just under your head. That's it, not under your shoulders. Just a 2 or 3 inch pillow. There you go. You comfortable?
Uh-huh.
Okay. So, and you can start this tomorrow or the next day. Don't start it if you're sore. If you're not sore, you can start it. Okay. So you do this exercise lying down always with a pillow under your head like this. And so what this does is it flexes your head a few inches off the table, naturally without any tension. And the pillow just does that. So from this position, you can rotate your head continuously from right to left like that, just like that, easy. And if it bothers you, don't go that far. Just you want to have no discomfort, no pain. Okay? Just like that. Now just try it yourself. Don't force it. Don't push. Just go from one side to the other without stopping. You'll do 50 rotations or 25 right and left sets 2 or 3 times a day. Yeah, doing it in the morning and the evening is good. And you can do it again, during the day if you can. That's even better.
Thanks, I appreciate that.
So how do you feel right now?
Well, not bad. I have to move around or do something to really know, I guess.
Okay. If this treatment works for you, it should be a slow, steady improvement. It's not going to be a magic cure or anything. Okay, you can get dressed now. How's your neck doing?
I can type now for an hour with no pain in my neck or my upper back.
Great.
The arm still bothers me quite a bit, though. There's no more sharpness to the pain, but it comes on if I do too much or if I lift things.
So you can type longer without pain. Does your arm bother you the same or less?
It's a little less often, but when it hurts, I know it's there.
So it's a little better, but still intense when it comes. Is that right?
Yeah.
Okay. Is there anything else different?
I can also read longer without any neck pain. I forgot about that.
That's great, John. It's important to keep an eye on what's changing and what isn't changing. That helps give us a realistic picture of the areas where the treatments are working well and any areas where they may not be as effective right now.
That sounds good to me.
So let's go to work. Does that hurt at all?
No, not at all. Are you using less pressure?
No, I'm going deeper into the fascia that I told you about. There are no more adhesions there, so I think we can skip that part from now on and concentrate on the adhesions in the ligaments and the suboccipital muscles at the back of your head.
Oh, that reminds me. I had to do a lot of standing last weekend at a wedding, and I got a headache, but it was a lot less intense than it normally are.
Well, that's really good news. It sounds like you're at a point where you'd benefit from using the neck relaxer block. It's a device that I developed a long time ago that I think will help diminish the occipital tension at the back of your neck more quickly. It's easy to use, and it's something you can do by yourself to lessen the tension at the back of your neck on a regular basis.
Well, that sounds good.
Okay, so this neck relaxer device has 3 edges, and each edge exerts a different amount of pressure. Edge 1 is very round, and edge 2 is semi-round, and edge 3 is pretty sharp. So when you use it, you lie face up on the floor or on your bed, and you put it under the back of your head, right where the base of your neck meets your skull, where I was just working. When you begin, start using the rounded edge. And if edge 1 is too uncomfortable, you put a washcloth over it or a towel to soften the intensity of the edge.
Okay.
Later, when your neck muscles are more relaxed, you can discard the cloth and lie directly right on the block, right on the wood.
All right.
So lying on the rounded edge, you rotate your head very slowly. Let's try that. So let's put it right at the occiput, right where your skull meets that there. There you go.
Okay.
So when you find, try rolling your head a little bit. And when you find a spot that's uncomfortable, stay there for a minute. You found a spot?
Yep, that's a little
Okay.
painful.
Okay. So now you're going to rest your head on each of these tender spots for 10 or 15 seconds, and never leave it in any one place for more than 30 seconds at a time. Or you might get kind of sore. And if stopping at any one of those points is kind of painful, just continually roll it through. Try just continually rolling through a spot that's kind of hurts a little bit, and see if that's a little easier. Is that a little easier?
Yeah, that's okay.
And come on back, and if the block, I can notice that it's slipping. Give me your hand, and if the block slips a little bit, rolls back, then you need to hold it with your hand like that.
Okay, that's better.
That's good. Okay, so let's take it out now, and let me just explain a little more. So once all the discomfort on the lower skull is diminished, and pretty much it's easy to do, you move the block up about 1/4 inch, just up a little bit higher on that muscle in the back of your head. It's called the occipital muscle. And when there's no discomfort at that level, you just move it a little bit higher. Okay? And the muscles you're working on are attached to the very lowest part of your skull, and they go about 1 inch. Okay? So when edge 1 no longer causes any discomfort, you move to edge 2, the semi-rounded edge, and then when that one is okay, you're going to move to edge 3, and it usually takes a couple of weeks or even a few months before you move to the next level. When it no longer causes, any discomfort on that second level, then go to the edge 3, which is the sharpest one, has the most pressure. And don't use the block for more than 4 or 5 minutes at a time, or else you'll get kind of sore. And if that happens, stop using the block until the soreness is completely gone. You can also increase the pressure by putting your forearm like this on your forehead. So what that does, it adds like 5 or 10 pounds while you're doing it. All right? So the neck relaxer device helps you to reduce your own level of tension without me, and it keeps your neck muscles in a very much more relaxed state. Okay? Keeps your neck free and easy, and you can use it forever. It's just a good thing to use.
Great.
And it works by applying excess pressure on the muscle tendon unit, which sends a message to your brain that there's too much pressure. And then the message is sent by the brain to the muscles to relax. Try it this week and see how it works for you. Do that before you buy it.
Great.
Okay? Great. Okay, you're feeling any discomfort traveling anywhere as I'm working here?
I feel it going down my arm now very faintly.
Okay. And how about when I go onto this one on the base of on the side of your neck here now?
Yeah, I feel that in my shoulder blade, but it's less intense than when you normally do that.
Okay. Okay. So let's work on your shoulder a little bit. Put your hand on your abdomen there. Okay. So how does that feel?
Annoying.
I guess I got it just right that time. Okay. Good. So now that you're regularly doing your neck exercise for your ligament, let's start the exercise program for your shoulder. Do you think you can make room and time in your schedule for another exercise every day?
Sure. If it will help, I'll do it. Being compulsive comes in handy sometimes.
Okay, I think your tendon has improved sufficiently to add this exercise into the mix. It's not so tender when I work on it now. Okay, it will help with your shoulder by preventing the scar tissue in the tendon from returning. It will also strengthen the tendon and the muscle. Because these structures have been injured for a while, there's been quite a bit of atrophy, which means that it has gotten weak over time. It's very common with these injuries. Muscles and tendons become very weak because the injury makes the person hesitant to use their arm, and that might be conscious or unconscious. Okay, so here's how you do this exercise. You just make a light fist, so just gently, just put it in the center of your chest, and you raise your arm, lift it out to the side, and let it hang here for a second or so, and then you bring it back like that.
All right.
You just do that over and over again, and you're going to have a weight. Doing it just like that, does that bother you, or it's
No,
okay?
that's all right.
That's fine. So let's try a weight here. So we'll start you with a 1 pound because it's pretty weak, and you come up and out, let it hang for a moment, and then bring it back, That's it, great. And then relax it a bit there, and then go out again, and let it hang there for a moment. Now, if it hurts you to go up, you start to the side, okay? And the idea is you work your way up so you're at about a 45-degree angle. That's a little
tight.
A little tight there, okay. So you just want to be, you might start here.
Okay.
And you want to be at 45 degrees because what you're doing is a combination of strength and stretch. You're taking it out, strength, you're letting it hang, stretch, and bringing it back, strength again. So you do 3 sets of 10.
Okay.
Do 10, and then you're going to rest for just a moment. You're going to just take it easy, rest for, a couple seconds. Do another 10, and then come back, rest for a moment, and a third 10. You want to do 3 repetitions of 10 for a total of 30. And you only want to do it until you feel a little bit tired.
Okay.
If, let's say, you do 12 and you're tired, you do another one, and that's it for that day. The next day, just try 1 or 2 more. So the signal is getting tired. That's when you stop.
Okay.
Once you can do 30, 3 repetitions of 10 without any discomfort or any tiredness, then you're ready for the next weight. So you go up to a 2-pound weight. Then if you do it again, you can go back to doing 15 or 20. You want to work it up till you're tired. Do 1 more, and there should be no discomfort. And when it feels easy, then you go up another weight. You should be able to do a lot of weight, probably up to 15 or 20 pounds, because you're pretty strong.
Okay.
Okay?
All right.
Good. Has there been any pain in your neck for the past 2 weeks?
No, nothing.
Any headaches?
No.
Good. After you change, don't get on the table. I'd like to check your neck movement before we get started. How many pounds are you up to with the shoulder exercise?
15 pounds, no problem.
Great. Now, does it hurt your arm when I work here at the side here?
No, not at all.
How about now? Does that send any discomfort down the shoulder blade area, the scapula?
No.
And does it hurt you at all when you lift things at work sometimes?
No, not anymore. I'm a little more careful than I used to be, but when I lifted some drywall last week, I didn't feel a thing.
How about your arm? Does the pain go down your arm anymore?
No. And that block thing doesn't hurt my neck when I use it. Should I continue to use that, or should I stop now?
Just use it once or twice a week to check the tension level that's in your neck. If it causes any discomfort, use it daily again for a while, until there's no discomfort or pain. That way you can make sure that the tension level in your neck stays low. So let's have you turn over now. I'm going to work a little bit on your back,
Okay.
your neck. Okay?
Yep, that's okay.
And how about that?
That's all right as well.
Okay. Now, is it different when I do it there?
It's a little more painful on the right
Okay.
side.
A little painful. Okay. How about that? Is that okay?
That's better.
All right, good. All right?
Mm-hmm.
Good. It's a lot looser now here. You were jumping around a while ago. Does that feel okay? Does that feel good, or does that feel borderline?
No, that feels good.
All right, good. That's letting go pretty good now. That's great. Okay. I'm going to work right on the top now. You just tell me if that's okay.
That's okay.
And now?
That's good.
Okay, great. That's great. Okay, I think that's good for today.
Great.
John, I think you're done with me. Let me see you in a month to check on you. And call in for an appointment if there's any recurrence. Keep up your neck exercises, your arm exercises for another month, and then you can just let them go.
That's great. Thank you.
You're welcome. Common questions practitioners ask. These are some of the common questions practitioners ask at our trainings. Is there an easy way to tell the difference between a disc injury and a ligament injury? Once you've learned the material in this program thoroughly, differentiating a disc injury from a ligament injury won't seem that difficult. For example, if the person has bilateral pain or pain that comes and goes, it's probably being caused by a ligament injury. On the other hand, if the person has constant pain that is referred all the way down the arm on only one side and also has specific weakness of the hand or fingers, this is likely to be caused by a disc pressing on a nerve root. Earlier on in the section on theory, we reviewed several signs and symptoms that help discriminate between disc and ligament injuries. In a person with a disc lesion, you can expect a number of these indicators pointing in the same direction. The more experience you have with clients, the easier it becomes to tell one sort of injury from another. After you've seen 10, 20, or 30 people with pain in the neck or back, the differences between disc and ligament injuries will seem more and more obvious. And of course, you'll always be making sure that your clients consult a physician. So while it's important that you can recognize the signs of a disc injury, it's the doctor that will actually diagnose the condition. Aren't muscle injuries common in the neck? In my experience, although the suboccipital muscles at the base of the skull are chronically injured with some frequency, other neck muscles are rarely injured for long periods of time. In each part of the body, some structures are under more mechanical stress than others, and therefore are more vulnerable to injury. For example, in the thigh, lower leg, and foot, muscles are frequently injured. In the shoulder, the majority of injuries affect the tendons or the glenohumeral joint. In the cervical, thoracic, and lumbar regions, the most common chronically injured structures are the ligaments. Muscles certainly get injured in these regions, but they heal much more quickly than ligament injuries. These statements may fly in the face of other things that you have learned. Just try out the techniques described in this program and see what happens. These methods have worked for me and the graduates of my orthopedic courses for decades. Why is it so important to have someone see a doctor? Whenever a client comes to see you with a pain problem, it's important to get a doctor's consultation to screen out serious medical conditions. One of my graduates told me about a client who was very afraid to see a doctor because he had had several bad experiences in a hospital. This man had great difficulty with head rotation and weakness on resisted rotation of the neck. The practitioner could tell that the client had some serious neck ligament injuries, but also knew that there could be other serious problems in the head and neck that were out of his scope of practice. The therapist made a good connection with the client, and with some prodding and encouragement, he went to see a doctor. As it turned out, this man had a brain tumor, and his visit to the doctor was an important turning point in his life. Failure to see a physician can have very serious consequences. I recently heard of a woman who had pain in her throat and did not want to see a physician. She chose to be treated by an alternative healthcare practitioner who did not provide a referral to a physician. It was not until 6 months later that she found out that she had potentially fatal throat cancer. She had lost 6 months of valuable time when she could have been getting treatment to help save her life. Massage therapists and body workers can practice safely within their area of expertise as long as they maintain their humility. The policy of referring clients to a physician to check for serious conditions is crucial for the integrity of the therapist and of the profession as a whole. Because I'm known for my work with pain and injuries, most of the clients I encounter have already been to see many physicians. This will likely be the case for you as well. But for those individuals in pain who have not seen a physician, it's your job to suggest that they do so. How do you get people to see a doctor when they don't want to? Many individuals have had bad experiences with doctors and other healthcare professionals. Medical professionals not in the mental health field often receive very little training in how to develop therapeutic relationships. Most have never taken courses in communication skills, relationship building, conflict resolution, customer service, and building a safe environment. In my view, these are crucial skills to have when dealing with something as personal and private as the human body. In your first session with a client, you're taking a major step in building a therapeutic relationship. As you take the history, perform the assessment tests, and then open up a dialogue, the client will get a good sense of whether or not he or she feels safe and comfortable with you. Your confidence, your presence, your voice tone, your gentleness and kindness, and your clear boundaries will give the client reason to trust you and believe what you say. If you have done all of this well, it may be much easier than you think to influence the person to see a doctor. It also really helps to have one or more excellent physicians in mind. Whenever I set up a practice in a new location, the first thing I do is go in search of good doctors. I ask everyone I know whose judgment I trust who their doctor is. I invite the doctor to lunch or breakfast. They have to eat sometime. I talk with them about their work and about what they like and don't like, and I see how I feel being with them. If I had a good experience, I begin to refer patients to that doctor for medical screening. I have sent hundreds of clients to doctors who don't rush them, speak in plain English, and do a thorough job. When clients persist in their reluctance to see a physician, I set a clear and kind boundary. At the end of the assessment session, I might say something like this: "You have a serious injury in your neck, and I would very much like to see if I can help you with it. In order to treat you in a responsible manner, I will need you to see a physician before I begin the treatment process. My training and knowledge are limited to certain areas of expertise, so I rely on physicians to screen out conditions that are outside my scope of practice. Once you've seen a physician, whether it's one I'm recommending to you or one you choose on your own, I would be happy to treat you." How do you get a person to come 2 or 3 times a week? It's often tough to get a client to come once a week. I'm often asked this question by practitioners who are new to orthopedic massage training. Performing relaxation massage is quite different from working on people who have pain and injury problems. Relaxation massage therapy may be quite effective if the client comes once a week, twice a month, or even once a month, depending on the degree of stress the person's body is under. In order for orthopedic massage to be effective, the client must usually come a minimum of twice a week and sometimes more frequently. However, the sessions can be shorter in duration. They're frequently just 30 minutes long. If you take the time to set the context of your work, getting someone to come 2 or 3 times a week is not that difficult. What do I mean by setting the context of your work? Most therapists are anxious to get the client on the table and start working on them right away. When dealing with a pain problem, that's not the best way to begin. Before doing any hands-on work, it's important to establish the therapeutic relationship. Take a slow and thorough history. Do all the assessment tests. Talk to the client about what you suggest and give the person plenty of time to ask you questions. This is all I do in the first session. At that point, I tell the client I want them to think seriously about whether or not they want the treatment. I tell them that it's a big commitment. I also explain that I don't take on any client unless I believe I have a good chance of being able to help them. Then I outline how I expect the treatment to progress. For instance, I might recommend that a client with multiple injuries come for 1-hour sessions twice a week for 6 to 8 weeks. Once they start to show improvement, I'd cut the sessions down to 45 minutes. As they continue to show improvement, I'd see them once a week for a while, and then once every other week. Meanwhile, I would be teaching the client exercises to do on a daily basis, and in certain cases, I might suggest they see a nutritionist for some dietary counseling. After providing all of this information, I ask the client to think about their decision for a few days and then give me a call. Only if the person absolutely decided to get treatment and insists on making an appointment right away do I go ahead and give them an appointment at the end of the assessment session. If an individual has financial constraints, I will in certain cases take them on for a nominal fee. If my life doesn't permit me to do that at that moment, I will refer them to a graduate of mine trained in orthopedic massage who is listed on my website. How do you increase your influence to help clients get well? Within a therapeutic context, your influence with clients is proportional to at least 4 factors. The relationship. The strength of the relationship you have with a client has a direct effect on your ability to influence that person. The relationship is strong if the client trusts you, feels safe with you, has had good experiences with you, and has a favorable impression of the things you've said and done. Your authority. As a healthcare practitioner, your professional authority is based on 2 factors. First, there's the authority vested in you by others. This includes your official education, training, and degrees, all the papers that you might hang on your wall. Second is the authority with which you speak. Speaking with authority demonstrates that you are confident and sure of what you're saying without being dogmatic or authoritarian. This also means you will give the client facts. Giving facts versus opinions. In any discussion with your clients, giving facts rather than personal opinions will make you more believable and enhance your professional influence. For example, if you're providing a referral, you might say, I've sent 8 people with a similar problem to this osteopath, and 6 of them reported to me that they felt about 90% better within a month or 2. This provides much greater credibility than saying, this osteopath is great. He is very knowledgeable and has helped a lot of people I know. I think it would be a good idea for you to see him. Honesty and humility. Telling the truth about what you know and what you don't know has a profound effect on the client's receptivity to what you say. Do you present your professional opinion as the only perspective that's valid or useful, or do you present it as an approach that you found to have a high likelihood of success? Post-test. 1. If resisted extension of the elbow is weak, what structure is injured? Answer. C7 nerve root. 2. True or false? The majority of chronic cervical pain is caused by injuries to muscles in the neck. Answer. False. 3. Pain down the medial border of the scapula is most commonly caused by injury to what structure? Answer. The intertransverse ligament at C7. 4. True or false? Whiplash describes a specific injury in the neck. Answer. False. The term whiplash only describes a violent movement which causes injuries in the neck. 5. Injuries to the neck occur most commonly at which level of the cervical spine? Answer. C5. We have covered the anatomy, assessment tests, anatomical palpation of all the important structures, and the theoretical underpinnings of cervical injuries. We have demonstrated many treatment techniques for treating injury to the fascia, muscles, and ligaments of the neck. I hope you find your newfound knowledge and skills useful and effective in helping the many people you treat throughout your life. Thank you.